Hey team, I am genuinely excited about this one because going through the literature for this talk, I learned new evidence-based protocols for me to put in practice and for how we should be using dexamethasone. And that's the whole point, right? As clinicians, it is not okay to do things just because that is how we have always done them. Our job is to stay current with the evidence and let it move us forward. So today, 15 minutes on perioperative DEX and orthopedic ERAS. Why we use it, how much we use, how to give it, and what to do about the diabetic patients that make all of us a little hesitant to use it. Let's get into it. Here's the plan. 5 stops. We'll start with why DEX matters clinically, the stress response, length of stay, PONV, and pain. Then we'll talk dose, because the PONV dose and the anti-inflammatory dose are not the same number, and that trips people up sometimes. After that, we talk about the route and administration, including that whole perineal burning issue, which is a real problem, but it's pretty easy to fix. Then safety in our diabetic patients, and we'll wrap it all up with a clean monitoring protocol. All right, section 1, the clinical benefits. This is the why we bother slide. Anti-inflammatory, decreased length of stay, decreased PONV, and decreased complications. Here's the mechanism. When we cut into a hip or a knee, the body throws a tantrum. IL-6, CRP, fibrinogen, all spike. That inflammatory cascade is what drives the pain, the swelling, the stiffness, the fatigue, and is part of the thrombosis risk as well. Dexamethasone walks in and turns the volume down on all of it, and the studies back that up. Breck showed that dexamethasone cut CRP roughly in half by post-op day 2. Molgard, if that's how you pronounce it, found that a 24 milligram dose reduced the IL-6 stress response by nearly half. And Abdelhamid showed that even a single 8 milligram dose improved pain scores, improved early mobility on the timed up and go test, gave patients stronger quads, and kept CRP down all the way through to post-op day 3. The key insight is this. The benefit comes from the anti-inflammatory action. PONV prevention is a bonus. That is why DEX is baked into all modern-day ERAS pathways. And this is what it actually looks like in outcomes. Over 200,000 patients in this evidence base. Length of stay, down about 4/10 of a day in the meta-analysis. And a similar drop in the Yoshida real-world data across 190,000 patients. Opioid consumption, 62% lower. And pain on the day of surgery, 2 full points lower on a 0 to 10 scale. Translation, our patients hurt less, they use less narcotics, and they go home sooner. That is the whole ERAS game in 4 numbers. Now, I know what you're thinking. Sure, it works, but what's the catch? This slide is the catch, or rather the lack of one. The left side, things DEX reduces. PONV, obviously, but also PE, DVT, AKI, and UTI, all of them. The right side has the things people worry about that DEX might cause. Surgical site infection, blood clots, GI bleed, periprosthetic joint infection, wound complications. The research shows no increased risk across tens of thousands of patients. So when someone says, I don't want to give DEX because I'm worried about whatever, the answer is almost always in the data, and the data says we are fine. And we are not out here freelancing. The American Association of Hip and Knee Surgeons, the American Academy of Orthopedic Surgeons, the Hip Society, the Knee Society, and the American Society of Regional Anesthesia and Pain Medicine, they all say the same thing. Strong evidence to give the drug. Reduce pain. Reduce opioids. Reduce post-op nausea vomiting. Palmer in 2024 went even further. 8 to 16 milligrams is reasonable and safe with a neutral to positive effect on basically every outcome we care about. Length of stay, VTE, mobility, delirium, acute kidney injury. If the guidelines are this aligned, it's our job to follow them. So here comes section 2, how much to give. This is where I need you to actually remember one important detail. The PONV dose and the anti-inflammatory dose are different numbers. Left column, post-op nausea, vomiting, prophy. 4 milligrams does it. De Oliveira looked at 60 RCTs, almost 7,000 patients. 4 to 5 milligrams and 8 to 10 milligrams give you essentially identical PONV reduction. The SAMBA guideline, 4 milligrams IV. Done. That's what you need for post-op nausea, vomiting. The right column, anti-inflammatory. This is a different conversation. Lex showed higher dose gives you better activity pain on post-op day 0, right after surgery, and on post-op day 1. Hannon studied this in total knees. He found that 16 milligrams gave you a little more pain control and a little less opioid use early on, but it came with a cost. Significantly higher glucose on post-op day 1. And by 48 hours, the benefit had basically washed away anyways. So 16 is doing more harm than good, and going above 20 gave you nothing better clinically. So 4 milligrams is all you want for anti-nausea. But if you want the full ERAS benefit, reduced pain, reduced inflammation, reduced stress response, you go up to the 8 to 10 milligram range. That's the sweet spot. Which brings us to, drumroll please, 8 to 10 milligrams IV at induction. That is the recommendation. Why that number? Robust CRP and IL-6 suppression across the total joint replacement literature. Real pain and opioid reduction. Most commonly studied is a single dose, and importantly, it avoids the significantly greater hyperglycemia you see when you give 16 to 20. The right panel, CMS guardrail, 180 milligrams sugar at discharge. Go above 10 milligrams and you start risking that target, especially in those borderline hemoglobin A1C patients. And one more thing. Wang in 2025 found big cases, a second dose at 24 hours further reduced 48-hour pain, length of stay, rescue analgesia, and PONV. No added adverse events. So don't be shy about it on the bigger procedures. Here comes section 3. How we actually give it. IV is the standard, oral is a backup, and the perineal burning issue, totally solvable. So here's a quick table, big picture. Every meta-analysis, every randomized control trial, every orthopedic guideline says to give it IV. The stress response suppression data, all IV. Timing-wise, IV peaks right when surgery starts hitting, and it gives 100% bioavailability. Oral dose is about 81% bioavailable. Absorption can get unpredictable with anxiety, opioids, and fasting. There's no head-to-head data in orthopedic literature. Now, I want to address something head-on. The reason we have facilities pushing for oral pre-op or pre-op administration at all is because they want to make sure these patients actually get the drug. And historically, they haven't been able to count on anesthesia to give it. That's a fair concern, and honestly, it's exactly why I put together this talk. If we as the anesthesia team are reliably giving 8 to 10 milligrams IV at induction on every orthopedic patient, the oral conversation goes away, as does the pre-op administration conversation. So here's the bottom line. IV at induction is ideal. Oral 8 to 10 milligrams pre-op is a fine documented fallback, but we should never be denying the drug. And that way we also earn back the trust with our facilities by showing them that we are a team that gives it every time. All right, this slide. 38% of patients report perineal pruritus when you push undiluted Dex fast. And yes, it's exactly what it sounds like. And no, the patients do not forget it. So let's not do that. 2 equally good fixes. Option 1, preoperative nursing dilutes it, 10 milligrams and 20 mLs of saline, and push it slow, like over a minute. Now, in 2012, GU published that the diluted dexamethasone in that 20 mLs of fluid over 30 seconds eliminated perineal pruritus. Eliminated, 0, no pruritus. We recommend 60 seconds just to give ourselves an extra safety margin and make sure that burning never happens. You could also do it in a piggyback on the pump over 5-10 minutes. Either way, the problem is solved. Option 2, and probably the more ideal option, anesthesia gives it in the OR after induction, but before surgical incision. Patient is asleep, patient does not care, everybody wins. Either one works, pick your lane and communicate. That way we make sure that we're not giving the patient a double dose and they're getting 20 milligrams. Okay, this is the part that everybody actually needs to hear. Diabetic patients, over 46,000 of them studied, no increased infection, and the increase in blood sugar was transient and manageable. So, no increased risk of infection. I'll say that again. No increased risk of infection. Jones-Labasso, 2,592 patients studied, diabetic patients across 16 randomized control trials. No increased SSI. Composite adverse events actually went down. Jones-Weir studied 34,298 diabetic joint replacement patients. No increased periprosthetic joint infection. No increased surgical site infection. And other post-op infections were reduced. Godshaw studied another 2,317 diabetic joint replacements. No increased PJI. And the thing driving post-op glucose wasn't patients getting dexamethasone, it was their hemoglobin A1C percentage. So when somebody says, but they're diabetic, the answer is the data says to give Decadron. Now, is there a glucose bump? Yes. Is it a problem? Mostly no. On the day of surgery, glucose peaks about 17 to 18 milligrams per deciliter above control, 4 to 8 hours after the dose. By post-op day 1, the average glucose is around 170 compared to 158 in patients who didn't get Dex. And importantly, the confidence interval stays below 200. By post-op day 2 and 3, there's no difference at all compared to placebo. So the bump is real, but it's transient and it resolves within 24 hours. The real driver of hyperglycemia is hemoglobin A1C, not Dex. Tang in 2024 showed that elevated pre-op hemoglobin A1C with a threshold around 7 to 7.3% is what predicts a fasting glucose over 200. And we're already excluding hemoglobin A1C over 8. So we're already filtering out those high-risk folks. What we need to be sure we have in place is a clean monitoring protocol. It needs to have these 4 components. Now, insulin adjustments are mostly going to be managed by the surgical and medical team, but it helps to know what they need to do so that we can educate them on a protocol. We should generally hold the oral agents on the day of surgery, and before surgery drop basal insulin about 75 to 80% of the normal, and NPH should drop in half the night before. After surgery, correctional doses may need to go up by like 40 to 60% while the steroids in their system. And then this is important. They need to then titrate that increased insulin back down within 24 to 48 hours, or you might wind up with a patient on the floor with hypoglycemia. So where this matters for us is preoperative and intraoperative. Knowing the home regimen helps us anticipate intraop glucose. And that way we can confidently give dexamethasone and hand the patient off to a team that's set up to manage their insulin and their blood sugar after surgery. And that's it. 6 takeaways. 1. Give Dex to everyone, including well-controlled diabetics. 2. 8 to 10 milligrams IV at induction is ideal. Big cases, a second dose at 24 hours. 3. IV is preferred over oral, but you can use oral as a fallback. We just never should skip it. 4. Dilute and slow push or OR administration, no more burning problem. And 5. Pair it with glucose, and insulin protocol. All right, that's it. Thanks, everyone. Go take great care of these patients. Questions at all, shoot me a text or an email, and I will get back to you as soon as I can. Thanks so much. Have a great day.